All right, we've got one lecture left, and it's really my privilege and honor to introduce Dr. Lex Hubbard. Dr. Hubbard received his internal medicine and pulmonary critical care training here at LSUS under Dr. George, and then went on to complete his anesthesia residency at Parkland. I know I've shared the story with Lex, and he's probably doesn't want to hear it again because he's a pretty humble guy, but in 1991 I was rounding on our brand new acute pain service in the Northeast, and my professor showed me a book that he had just published, and inside was a chapter written by Dr. Hubbard, and my professor said that he was 5 years ahead of his time. I think there are certain people who are in our practice and in our specialty who are safeguards to us all, who are always looking ahead, pushing ahead, always trying to do better, and can see the future and sort of know where the specialty's going, and have been good stewards of guiding us. And I think Lex is definitely one of those, always considered one of the finest anesthesiologists in the state of Louisiana and probably in the South. And my privilege to introduce Dr. Lex Hubbard.
They're helping me out with the audio visual here, slideshow. It's been 23 years since I gave a formal lecture, but I've given this lecture monthly, at least monthly, in these last 23 years to hospital administrators and physicians that I've worked with. I wish there were more hospital administrators here because I really want to push these ideas. I didn't have to make this disclosure before, but now I think I'm obligated to say that I have no relationship with industry to disclose relevant to the content of this CME activity. I'll tell you what, if you want to inspire yourself to create security for your practice, get you one of these. Because this is why I wanted to have it. It's my family that made me want to do well in my practice. And I found opportunities from the almost from the very beginning to establish security for my practice by concentrating on patient care. And that's where you're going to find security, is improving surgical outcomes. In the future, you're going to hear this phrase, enhanced recovery after surgery, if you haven't heard it already, because it's very prevalent in our literature now. So the objectives of my discussion here are to expand anesthesiologists' role by participating in patient care beyond the PACU. Initially, by developing an acute pain management service, if you are not already participating in one. I'm sorry for I'm recovering from upper respiratory tract infection. I want to focus on the term emerging opportunities for anesthesiologists to take a leadership role in managing surgical outcomes. The difference between being an anesthesiologist and an anesthetist is to be able to be involved in the patient's care beyond the PACU to improve outcomes. And who wouldn't want to, by a multimodal intervention, reduce morbidity and deconditioning of the patient from the surgical procedure so that the patient returns to a baseline state earlier. I'm going to use my career path as a reflection and an argument for anesthesiologists being involved in managing surgical outcomes. I did internal medicine and pulmonary medicine in this institution. The library over here was very important to me, and I'll tell you why in a minute. Then I went to Dallas and I became an anesthesiologist, returning to Shreveport immediately afterwards. But before I left Shreveport, I did practice pulmonary medicine for a short period of time. I was taking care of patients in the postoperative period, and that's where I learned to manage surgical pathophysiology. To some extent, there was a lot of opportunity beyond that I learned only after I became an anesthesiologist. In my anesthesia training, I learned what you guys are learning now, airway management, the pharmacology of anesthesiology, how to do general anesthesia and regional anesthesia. And we're doing a lot of regional anesthesia now that we didn't do when I was in my training. And I learned the importance of comorbidity in managing the anesthetized and surgical patient. I've been at the three major private hospitals here in Shreveport, or three major private hospitals in Shreveport. I was initially at Willis Knighton's main campus, then Hubbard Medical Center for 10 years, and now I've been at Willis Knighton Pierremont since it opened. My aha moment came in 1984 when I thought I was going to leave Shreveport and go to North Carolina. I was on an interview at Presbyterian Hospital in Charlotte when I was visiting with an anesthesiologist who had just completed providing services for patients who had an abdominal aortic aneurysm resection. And this is the old way. We opened them from the xiphoid to the symphysis pubis. We left them on the ventilator for 6 to 24 hours and essentially anesthetized during that period. Well, I went to the bedside with the patient. He'd just completed the services for this patient having an aneurysm resection. And the patient was alert, extubated, able to communicate with us, pain-free, not on a ventilator. And this was very different from what I witnessed in my practice. So with this observation, I understood that being an anesthesiologist meant more than seeing patients through the PACU, that anesthesiologists have knowledge and skills to improve surgical outcome. And I made a commitment to myself with this one observation that no matter where I went, I was going to use these techniques to improve outcomes. I was at Willis Knighton's main campus for 4 years after that, and I learned to do thoracic epidurals. And for patients who were going to be admitted to the intensive care unit after thoracic or abdominal surgical procedures, I would put in a thoracic epidural catheter and infuse local anesthetics and narcotics and have a significantly improved outcome relative to the norm. I got so many requests to do this, and I was seeing such a great outcome, I wanted to find out why. And I came to the library, and this is one of the best 10 decisions of my professional career was to ask myself the question, why are these patients so much better than the patients that I had taken care of previously? And I figuratively met Dr. Henrik Kalit from Copenhagen, Denmark, who at the time was a professor of surgery in the section of gastrointestinal surgery. And you can see now he's a professor of surgery, but now in this section of pathophysiology. I can call him a friend now, but at any rate, back then I just looked at his literature, and what I found there was that he was doing research in surgical pathophysiology and how to manage it. And his main focus was how to manage pain. And what he was discovering that was by managing pain, one determinant of outcome, you have an indirect or direct benefit on all of the other determinants of outcome. So I was still at Willis Knighton, and that's what I was learning from Dr. Kalit's research. And I left Willis Knighton and went to Shreveport Medical Center, where with these guys, about the time that you were discussing our success with the acute pain management service, I was working with these guys. One of them is right back here, and there were 4 others, but we developed a state-of-the-art acute pain management service. We were pushing ourselves out of the PACU into the hospital to take care of patients. That's where the juice of practicing anesthesia really is, if you don't know it yet. The keys to our success were that we had institutional commitment, we had multidisciplinary support from administration, physicians, nurses, and pharmacists. We had documents. I meant to pull these up here. We had documents describing our service. Yale didn't base their pain management service on these documents, but Johns Hopkins did. They came and we were educators too. But these are the documents that describe the acute pain management service, a very complete policy and procedure manual of the service. We had education of bedside nurses, and we had standardization of the service. It's very important to standardize your services, because If you're not achieving the goals and you don't know, and there's not a standard process by which you do something, you don't know what to change to create a successful service. So standardization was a very important aspect of our success. This is Chris Passero. She was a nurse that committed to us in 1989 to help us write this document and do dot the I's and cross the T's to make sure the pain management service worked well. She's had a 25-year career in acute pain management nursing. She's a nationally recognized figure now, and she did live in Shreveport and work with us directly. Our pain management service was very thorough. We would educate the patients preoperatively, and then the nurses, we had nurses around the clock who would go by and assess the patients. One on every shift would go by and assess the patients on the pain management service. We'd have as many as 50, this was at Shreveport. We'd have as many as 50 patients on the pain management service, and the nurses would go by on every shift to make sure that we were achieving the goals that we had set out to achieve. Our services back then were relatively simple: intravenous patient-controlled analgesia, which you're all familiar with, and we used epidural, narcotic, and local anesthetic infusions. Do y'all do that very much? Raise your hand if somebody does this. We do it. Y'all do it a lot? It's the Cadillac for pain control. Here you see me putting in, this was when I had brown hair still. You see me putting in a thoracic epidural catheter for a patient who's going to have an abdominal aortic aneurysm resection. When people know that you're interested in taking care of patients in the postoperative period, you'll be interested to know, you'll be excited to know that they'll come to you with requests, and I know that Dr. Larson has these requests. They'll come to you for some solutions to problems. So this is a patient who had a crushed elbow in the early 1990s, and the surgeons wanted him to be in a continuous passive motion device postoperatively. So this is in the early 90s. I fashioned a axillary catheter out of an epidural tray and infused local anesthetics in the postoperative period. Now, that's kind of, everybody does that, do they not? But we didn't do that in 1990. I want to go to the standardization now of the services that we offer, but I haven't really come close to completing my comments about enhanced recovery after surgery. This is the standardization which accrues to the benefit of patients because everybody's familiar. When this document goes on the chart, they know, everybody in the hospital knows that the anesthesiologists have committed themselves to satisfying the pain management needs of the patient in the postoperative period. And it accrues to the benefit of everybody involved in the patient's care. I'm going to break this down a little bit by sections. In the first column there, you see that we use interspinal Duromorph and followed by PCA. Then we use continuous infusions in the epidural space or by peripheral nerves. Then we use IV PCA alone, and finally interspinal narcotics alone. The second section is about managing side effects and breakthrough pain. And the third section, which I think is going to go through a lot of evolution in the next few years, is multimodal analgesia, what drugs to use other than local anesthetics and narcotics for pain control, especially getting away from narcotics because they are the things that really keep patients in the hospital and cause a lot of problems. Backing up to 1990, the real significance of this picture is a symbol on that cake. That's my birthday cake in 1990, and you can see that we were evaluating pain, at least for postoperative patients, as the fifth vital sign. And it wasn't until a half decade later that accrediting agencies made us evaluate pain as the fifth vital sign. Now, kind of for the climax of where I want to get to. We are with managing outcomes as anesthesiologists where we were with managing pain before 1990. Before our acute pain management service was developed. But I think it is anesthesiologists who should take a leadership role in improving surgical outcomes. and I've been thinking about this for quite a while. I gave a lecture series in May 1990 in Washington, D.C., and you can see at 8:45 there, I started talking already about patient outcomes as a true bottom line. And my last slide was acute pain management service versus acute rehabilitative service, because that was what I was beginning to think we should become, is acute rehabilitative service, or managed outcome service, or enhanced recovery after surgery service. No longer would we just concentrate on managing pain as a way to improve outcome. We would concentrate on managing all of the determinants of outcome equally, because they're all important. This is 1997, and this is a document that came out of a committee that I kind of convened to create a managed outcome service. And although it's not sophisticated relative to what we know today with regards to managing surgical pathophysiology, it was a stab in the dark to try to get it done. Again, this was presented at Shreveport, and even though we had good success with the acute pain management service, the market just was not right for anesthesiologists to dig that deep into managing outcomes. In 1999, I had Dr. Kalick come to Willis, Knighton, Pierremont shortly after it opened to discuss managing surgical outcomes. You see under his picture there, I got this slide off of the internet. Under his picture it says, even though he's a surgeon, it says Denmark's best known anesthetist. He speaks all over the United States at anesthesia and surgical conferences. He's the father of fast track surgery, which started in Europe, and there's some of it here in the United States now. But it was this research that was the foundation, his research initially and then others in Europe, that was the foundation for the Enhanced Recovery After Surgery Society. Go to the internet, look it up, ERAS Society. You can become a member free of charge. You can get their protocols of care. But it was his research, and I think it's just phenomenal that I found him in the library over here in the mid-'80s. But at any rate, his research led to the creation of the Enhanced Recovery After Surgery Society. So where are we today? Chris Passero, who I mentioned, says that there's still nobody that really is as interested as we are in our practice in managing pain in the postoperative period, and I think that's kind of a stretch, but we are very interested in it. I'm interested in doing this, going to the next level, and I'm beginning to get some traction because there are these protocols from the ERAS Society are showing that there are really significantly improved outcomes with the protocols of care. And we as anesthesiologists have to be involved in that care, and I'll show you why in a minute. In the United States, there's an effort to do this by the American Society of Anesthesiologists, known as the perioperative surgical home, but we are far, far behind what's going on in Europe and Canada. There's a few efforts in the United States to do ERAS protocols. So does it work? This is, I'm kind of having a proof of concept in my hospital. This is a patient who had a cystectomy, and I got his permission to use his pictures in my presentation today. But we changed this course of care, and anesthesiologists have to be involved in this. I let him have clear liquids up until 2 hours prior to the surgical procedure. I let him eat 6 hours preoperatively. I put in a thoracic epidural preoperatively, and I assured myself that it was in the right location by creating a sympathectomy with local anesthetic before he went into the operating room. If you don't have a thoracic epidural, you can't achieve this nearly as efficiently because you want to get away with narcotics. This patient did not have a narcotic except what he received in the epidural space during his hospitalization. You see him there in the upper left-hand corner in the 6th postoperative hour. Next to that is the 1st postoperative day, and below that is the 4th postoperative day, the day of discharge. Now, how does that compare? On the bottom there is James. He's a 74-year-old man. He was the 2nd oldest of all the patients, of the patients that I looked at their chart. These are the last 8 patients who had had a cystectomy prior to James. He was the 2nd oldest. He was in the ICU for 1 day. The patients prior to him, excluding the outlier, were in from 3 to 7 days. Their diets were not advanced until the 5th to 7th postoperative day. James never stopped drinking water. When he got into the recovery room, he was alert. He was comfortable because of the thoracic epidural. He was alert, and I gave him some chewing gum. And he started chewing gum and started drinking water immediately postoperatively. And he was started on liquids on the 3rd postoperative day. The other patients were not started on diets for much longer than that. His length of stay was 5 days, and the other patients were 8 to 11 days, excluding the outlier. Now, hospital administrators would love to see this kind of result for patients who have a capitated or who are covered by contract, so that no matter what their length of stay is, you're only going to get so many dollars. So where are we in demand for this, the creation of these services in our country? This is an article from the Wall Street Journal this year. It's prescription for better recovery from surgery. This article addresses specifically efforts at Duke to implement enhanced recovery after surgery programs. Y'all all get this anesthesiology newsletter. This is the April. I have 3 articles here from the April newsletter, and that are addressing the enhanced recovery after surgery efforts. Goal-directed fluid therapy reduces morbidity and cost. That's a very important thing. How to manage fluids appropriately, using new technology to do that. Maybe even the echo. Boy, I wish I was in training now. This is another article. The ERAS approach in older patients lowers morbidity and length of hospital stay. And finally, the ERAS program for complex hernias yields improvements. Anesthesiologists can be significantly rewarded by being involved in the postoperative recovery of patients, improve outcome, decrease cost, decrease their morbidity, and decrease their deconditioning. It's been a long time since I started thinking about this. So it's been a very long time. My children were very, very little when I started thinking about it, and we haven't implemented it yet in our hospital, not to its full potential. But my children there are left to right. Lex is a software engineer. Dorothy is an attorney. Jill is a CRNA. And Tyson is a software engineer too. Thank you. Any questions?
What's the main hesitation for the hospital administration? Is it cost factor?
You know, anesthesiologists are not, well, you know this, you're an anesthesiologist. Anesthesiologists are not really, for the most part, are not committed to patient involvement in the postoperative period beyond the PACU. And despite our commitment to do that, there are still turf battles to address. And some of those turf battles are, one of them in particular is, I would like to take a leadership role in doing this. And that's obvious to everybody that's around me, because I think the outcomes, seeing these different outcomes are so great. But I need a partner in the internal medicine side, and then that creates a whole turf battle. Who's going to be my partner? That type of turf battle. And then you have the conflicting orders. Anesthesiologists are attempting to improve outcomes by their techniques and attempting to improve the pain management techniques. And then you have people coming by and thinking they know a better way to do it. So there's a lot of turf battles that we have to resolve yet. But there are going to be changes because the market's forcing us, because of accrediting agencies evaluating our outcomes and readmissions and that thing. I think we're going to have the opportunity to see this flourish. Correct.
Are you being compensated for doing this work?
Well, you know, when this is my twin brother. Whenever I started doing acute pain management, there wasn't a good coding for compensation for the services that we were providing, because we were so early on in the creation of this service. But we did find a way to create a revenue stream for the effort that we were making. And I thought it was justifiable. I mean, I would have patients who traditionally had been on a ventilator for 24 hours who are now participating in their care in the first post-operative day. So I think as things evolve, we will find a way using E and M codes to get compensated for the efforts that we make in this area. But,
Lex, how do you manage now, because there are anticoagulations these people are?
Anticoagulants?
And how do you manage it nowadays? Because that was different in 19 when you were talking about it.
Right.
Now everybody's on anticoagulations and all kind of things.
Well, we do have to recognize the timing of removing the epidural with respect to the last time the patient received a heparin or Lovenox or whatever it is that they're receiving. We've had to. We work with the colorectal group at Willis Knighton, and we've had to modify our pain management strategies for them because they really were really aggressive about their anticoagulations for the patient in the postoperative period, and they don't want us to put epidurals in them. And there are other ways now that make it as efficient for the patient. In the first 24 hours, 36 hours, that's the most difficult time to manage a patient's pain. And we can get them through that period by doing two things. First, doing a spinal anesthetic, and when we do a spinal anesthetic, limit the amount of local that we use, but putting in Pierremont into the spinal fluid. Then doing, I'm not able to do it yet, but Dr. Larson tells me that he's using tap blocks with Exparel and getting great results. That's what I want to do, but unfortunately I can't do that at my hospital yet, but because they won't let me have access to the drug. But that the anticoagulant is a problem with regards to placing an epidural. But I'm telling you, the benefit in Europe, it's not a problem. They don't use anticoagulants, not as much. And the reason they don't use them as much is because they have ERAS protocols. And what does the ERAS protocol do? They mobilize the patient. So they're not using as much as we do. Yes, sir.
In regards to dosing your thoracic epidurals, do you find huge differences in giving local anesthetic prior to incision as opposed to prior to waking up and starting with infusion?
Are you I put in a thoracic epidural, and I use 0.75% bupivacaine, 3 to 4 cc's prior to the incision, okay? And I give them 2 milligrams of Pierremont. Then I start a local anesthetic infusion with 0.05 milligrams of morphine in the 1/4% in 8% bupivacaine, and infuse it at 4 cc's an hour. An interesting thing about narcotics, if you and I are getting oral narcotics for pain control, there may be as much as a 10-fold variation in what it takes to get us comfortable. It may take you 10 and me 1 milligram. If we move that into the intravenous, if we give it intravenously, it's more likely that you and I will have a closer, maybe it'll take me, maybe take you 2 milligrams and me 1. But if we give it into the either intrathecally or epidural, it's 1-on-1. what makes you comfortable will make me comfortable. And it's unbelievable how true that is. It's rare. I mean, whenever I do a patient that had a thoracotomy or an abdominal incision and they've got in a thoracic epidural, it's rare that they have pain post-operatively. And I dose them before they ever make an incision. You know. Yes, sir.
Did you face resistance from the surgeon when you first started, and how would you think the best way to handle that?
Well, you know, I was fortunate. I had been in the community as a pulmonary disease specialist and was involved in patient care outside of the operating room. And then I showed the commitment to what it is I wanted to do with regards to managing pain. So I went to the surgery meeting and I talked to all of them. I said, we want to enter into a conversation with your patients preoperatively to manage their pain postoperatively. All of you that don't want us to do that, sign the list. And about 50% of the surgeons signed the list. And one of them asked me, are you going to get compensated for this? I said, yeah, I'm going to take the phone calls. I'm going to get compensated for it. So about half of them said no. In about 6 months, because of the dedication of my anesthesiology partners and that nurse, Chris Becerro, in 6 months, we had them all. We were taking care of all of the pain in the post-operative period. So we did have some resistance. It didn't last long because we were doing such a good job.
Are you guys doing any other stuff, such as like intraoperative magnesium or ketamine, preoperative gabapentin?
That's what the slide, I don't know if I said anything about it, but that slide that I had about the multimodal analgesia, that's going to go through a lot of change in the next few years as we learn what drugs are most important for adjuvant analgesia. And a drug that I use all the time, and it's not commonly used, is Robaxin, because I think there's a lot of muscle spasm pain, or a lot of pain as a result of muscle spasm in the postoperative period. I use Robaxin very routinely, Tylenol, and a non-steroidal anti-inflammatory drug. But magnesium, I know it's out there, ketamine infusions, lidocaine infusions, but what's the most appropriate drug to use when? I don't know. That's where the standardization is going to be important. And that's why Dr. Larson and I want to have control of the analgesic requirements for patients in the postoperative period so we can figure out what works and make it standardized and uniform so the patients get a really good benefit, less morbidity, less deconditioning. Yeah, Rex?
Surgeons don't get compensated for those phone calls, so they very happy. Someone who's efficient and can take care of the patient.
Okay. Is that all? Thank you very much. Help you do it here? Yeah. I mean, they want it.
Thank you, Dr. Hubbard, for a great lecture. So next we'll have closing with Dr. Shaw for 5 minutes. Everybody knows he's the senior most faculty in our department, and for those who don't know, he's an associate professor here at LSU Health.
Well, I'm sure you enjoy this meeting, so we are going to have every year now, or every 6 months. I think this is the best meeting I attended at LSU after a long, long time. And this was well planned by Shilpa, a lot of hard work, a lot of commitments, and I think Dr. Gangur has a lot of help. Without them, this was not possible. And Dr. Martinez, who talked yesterday, so good. I mean, he was one of the best lectures I have attended. I mean, for residents to learn those basic science subjects, to be good at the blood gases and how the lung functions and so forth. And this afternoon also an excellent lecture. Dr. Walden talked about very clinical pediatrics, Airway management. That was one of the best lectures. And Dr. Hubbard, I know him for many years. And this is something great idea, and I think our department can improve from those. So, and most importantly, she has spent days and nights and hours and amount of time, I don't know how much she has spent, but she did an excellent job.
Thank you very much, Dr. Shaw, for those words. And before we go to Zadok Conference Center for the workshop, downstairs on the ground floor next to Atrium Delhi, I just wanted to thank you few people for making all this happen, for this coming all together. First of all, I'd like to thank all the audience who are here, and I hope you all had a great Saturday, even very knowledgeable Saturday, I would say. So I would thank Dr. Fox for giving me this opportunity to do such a conference, and also all our planning committee members, Dr. Virendra Koyalmuri, who helped me guide because he was the one who did before. And also I would like to thank Dr. Gangor, who got a great guest speaker, and also Dr. Fox, who got another guest speaker, Dr. Hubbard, and my husband, Harish, who got Dr. Martinez from Miami. So I really thank them. I think they were the best speakers we had, and of course our local speakers, Dr. Heron and as well as Dr. Sauce. So I would also like to thank some of the people who morally supported me, Dr. Chandler and Dr. Shah. Also, everybody who's going to participate in the workshop, thank you for participating in this and making everything successful. Last but not the least, I would like to thank all the residents who have helped me, especially Dr. Catalani Blas, Dr. Sai, and Yuri, as well as Gurleen, and who else I'm forgetting? So Dr. Keflamarian. So, and also, yes, and I would like to thank the exhibitors who came here, especially Jonathan Cottrell from Medical Specialties, who helped us get the mannequins, and Dr. Blas, Catalani, and Dr. Sauce helped a lot for the workshop. I really thank them very much. And also I thank the administrative staff, Gail Harris, the CME director, and Trish and Deborah Richmond for helping me. Thank you all very much. So we'll go to the Zadok Conference Center downstairs. So we have multiple stations. There are totally, I'll just categorize as 4. One for adult airway, one for pediatric, the other one is for lung isolation techniques, and the last one is for ultrasound. So please make use of them. They're very good teachers. Thank you. Thank you all.